Hello and welcome to another episode of Everything Digital Health. I'm Marcus Bohr, I'm a GP and clinical informatician. Today I'm joined by Nick Booth, who's another GP and clinical informatician who I've known for getting on for 15 years now, since I started in GP Informatics. And he's somebody who I met through the Royal College of GPs Health Informatics Group. Welcome to the show, Nick. Thank you for great to have you on the show. So do you want to tell us a little bit about how your journey to informatics and how you got there? Because it's not something everybody does, is it?
No, and I'm sure it might not be different. I mean, thank you for inviting me. It's a pleasure to be on this. And yeah, well, I mean, I can remember being interested in computers right from the get-go. I was a very strange child, and I remember going to the library in the village where we lived near Sunderland with my mother when I was about 6, and I got a book out about radar. And it took me to the library to get technology books out rather than anything else. And I suppose I first came across computers on Tomorrow's World. Many people may have also done that, and I became immediately fascinated.
I used to love that program. That was my favorite show.
Yeah, and it was on every Thursday. I remember Thursdays coming home from school. There was a bonanza of great TV. I can't remember what the other programs were. Top of the Pops is probably one of them. And yeah, so I also have an early memory of doing Latin homework. It was a sort of big subject at the school I was sent to, and I couldn't do a translation once. I was pretty good at Latin, so, and I knew what all the words meant, and I knew what all of the bits of syntax and grammar were, but I couldn't for the life of me get any sense out of it. And I just thought, one day computers will be able to do this. Anyway, computers never really came up again until I was at school. When I was about 16, I think we had computer lessons, two periods a week at school, and we got to punch cards and learn Fortran and stuff like that. I found it a bit dull, actually, to be honest. It wasn't as sexy as I thought it would be. And I don't think I got interested in computers again until general practice. But first, let's talk about medical school. I mean, I went to Cambridge Medical School. There was nothing about Cambridge which fascinated me other than this vast building where there was a single computer near Downing Street in Cambridge, where apparently there was a fantastically large, clever computer. And I thought, well, it would be good to go in there, but I never did. And I did 3 years in Cambridge and then went to King's College Hospital in London. And that's when it really got interesting, actually, in retrospect, because this was just a normal medical education as far as I was concerned, and I had no understanding of how unusual it was. But there was a guy on the medical wards called Professor John Anderson, who was a Geordie, he had a broad Geordie accent, and he was one of the guys on the endocrinology ward, which was one of the first wards I went to. And in the corner of each ward was a computer, and they were covered in dust. So I asked what these were for. And apparently the houseman from 1971 until 1975, I was there in 1975, had done all their clerking in on a computer, and they'd given it up because basically it took too much time. So there's a lesson.
Interesting that it took longer on a computer, because that's definitely what people find in.
Well, it was typing. Yeah, it was typing, and we'll come to the GP computer systems, which I got interested in later, but they didn't suffer from that. But not only that, but we used problem-orientated medical records on that ward, and we had problem lists, which were divided into active problem lists and resolved problem lists.
Cool.
We were taught about Larry Weed.
Yeah.
And I remember having a patient with renal failure, and I researched the patient with renal failure, and they had something, some kind of glomerulonephrotic syndrome. That's what they had. And so I went to the library, and there was a systematic nomenclature of pathology, SNOP book, which had this really huge list of every possible disease that you could imagine. And I got into the glomerulonephritis chapter, and I was finding nephrotic syndrome and all kinds of other things, Goodpasture's syndrome. And it was basically a classification, which was a precursor of SNOMED. So at King's, in my first year, I learned about SNOMED, well, SNOP, Larry Weed. I don't know if you've seen Larry Weed's tutorials.
So on this channel,
absolutely.
I have a playlist of must-watch videos, which are not my videos. These are other people's videos. And Larry Weed, I think, is first on that list. And it's the 1971 Grand Round or something like that. It's in black and white.
Right.
He's got this huge neck-bound microphone hanging off him, yeah. But it's absolutely brilliant for the description of problem-oriented medical records, but also just the general problem of the difficulty of managing records and how important they are to healthcare. I think he describes it as like you're a triumph because of it, or you're a failure because of it. You know, it's the medical record that makes the difference between medical triumph and medical failure. It's really cool.
Yes, and I can remember seeing that tutorial on some kind of old-fashioned projector in a tutorial room at King's.
Wow.
In 1975, probably. So, you know, they were teaching stuff then, which I don't think many doctors in training have come across. And it's just a quirk of where I happened to be at the time. But later on in that 3-year period, we did GP modules, and we were taught about a guy called John Fry, and he really got my interest. And John Fry was a GP in Beckenham at that time, and he'd written books which are basically lists of the things he came across in his practice. So he's a completely obsessional GP, and he had fantastic records. He knew how many consultations he'd done with each patient and what his consultation rate was per year. And I just found it, really interesting. I also recall seeing that we got taught about Tay-Sachs disease or something like that in pediatrics, and we had a book by Roy Meadows, I think, who later fell from grace. But in the back there was a thing about how often does a GP in the United Kingdom see a case of Tay-Sachs disease, and it's once every 3,000 years. So you kind of wonder,
Wow.
why are we teaching? Why are we teaching this? Anyway,
yeah.
So I was really, really interested in data, and then I got on with the rest of my career, and I started off after my house jobs. I did pediatrics in Newcastle, and they had ultrasound machines, and there were computers involved in the ultrasound machines diagnosing 3D ultrasound, doing stuff in pediatric cardiology, and I really loved that. And we were doing lots of stuff, so it was a teaching hospital job. I really liked pediatrics, but unfortunately, after 2 years, I realised I couldn't take the pace basically because of the pediatrician, especially doing neonates.
It's neonates that people tend to find just impossible to keep up with, I think.
Yeah, pediatric cardiology was just as bad, actually. I mean, I love pediatric cardiology. I did it 6 months, but you would do Friday, Saturday, Sunday shifts, and you basically not sleep between Friday morning and Monday night, and it was awful.
Well, this is in the bad old days as well. Before the new contract came in for junior doctors in the early 2000s, when there were more or less no limits on hours. Before the working time directive that came in, whilst I was a junior doctor, And that, at the very least, I mean, it caused us to end up on shifts. We ended up moving to full shifts instead of on calls. But at least it meant we never had to do those 120-hour weeks.
Yeah, so I was doing a 120-hour week, and I mean, the only good thing was that A, you got paid quite well for it, and B, well, you didn't. I mean, you got a third of your normal rate for the time over 40 hours, but
yeah, it's cheaper than in the hospital.
And the other thing was that you were so tired the rest of the week that you couldn't spend it. So you collected
yeah, you just make money.
Yeah.
So from there, you went into general practice?
So I joined the vocational training scheme, and I got interested in computers again. So they were doing things called, I can't remember what it was called, MIQUEST for GPs, I think. Yeah, MIQUEST for GPs, which was some kind of government-sponsored project. And one or two of the vocational training scheme practices in the Northeast had doctors who were interested in that. I remember Neil Jones was involved in his practice with a guy called Alistair Malcolm, who was a GP in Durham. And he had an Apple Macintosh-based system in his practice. And
wow.
These were the few practices that were computerized before the big change to BAMB and AAH Meditel.
Before it became kind of mainstreamed.
Before it became mainstream, yeah. So, okay, so there's something about the vocational training scheme which I recall, which was very interested, and that was there was a great wise bloke called Donald Irvin. Not everybody liked him, but he eventually became chairman of the GMC. But he was a GP from Ashington, and he did all of the early research on vocational training schemes and making them evidence-based, and he had a massive brain. And I enjoyed his tutorials. He was very challenging, and he taught us about being able to describe what you do. And there's a guy called Donabedian who was some researcher in this domain, and he said that you have to describe what you do in terms of the structure of the practice, the processes that you go through in looking after patients, and the outcomes of those patients. And it was pretty clear that the structure of most GPs in GP practices in the 1980s was inadequate to look after people comprehensively in most of them, and that the processes were not captured in any kind of way, and virtually no one had any idea what the outcomes were. So, if you did diabetic clinics, did you have a structure in your practice which enabled you to do them properly? Did you have dipsticks and nurses maybe to help? Did you have time to do that? What processes did you go through? Did you recall your patients adequately? What did you do when you saw them? Did you measure their blood pressure and say, it's a bit high, but we'll wait till next time, which is what we did. And then the outcome, did you ever work out how many of your diabetics got amputated feet or ischemic heart disease? And the answer was no. Nobody knew how to do that. And all of the GP practices in the vocational training scheme had to have repeat prescription systems and disease registers. And those are non-trivial things to set up if you're in practice, which is just got boxes full of Lloyd George envelopes, which have got pithy one-line notes since 1946. And, no problem sheet, no problem orientation, no active result problem.
Yeah.
If you're starting from that basis, it's really difficult. Anyway, time went on, and I got appointed as a GP principal to a practice in North England. And I said during the interview that I wanted the practice to become a training practice. And so they put me in charge of that, if you like. And I couldn't see how we could get a repeat prescribing system going in a satisfactory way, and even approach getting a comprehensive disease index without having a computer.
Yeah.
So the British Computer Society. Oh, God, sorry.
It's interesting how we take for granted information management tools, like just being able to search a list. We think now that's a computerized problem that we think of as trivial. But if you wanted to have a load of cards, so if you didn't have a computer and you just had cards with patients' names on them and maybe what conditions they had, to sort through that list and find out all the ones that had a certain complication or had a certain condition was either a manual task or, I mean, there were kind of ingenious mechanical devices invented where you had like holes punched in the sides of cards and you put kind of a knitting needle through um, all that particular hole, and it would, when you lift the knitting needle, it would
Yeah.
pull out just the
I
cards
was,
that had a hole and no slot. I mean,
I was going to talk to you about that. So what, apart from John in the British Computer Society, I made friends with another GP in Northumberland called Malcolm Aylett, who lived in a village called Wooler, which is quite a lot. Northumberland's a big county.
big. I've been to Wooler though. I know Wooler. It's right out in the
Wooler,
middle.
yeah, and Malcolm Aylett was a single-handed general practitioner. I think he'd come up from a practice in Wiltshire or something, and he needed to be on his own because he was so obsessional. And it's a sort of feature of people, you know, in the whole of this area we're talking about. The number of obsessional people is very high, and of course, you realise that this is a quality attribute to have if you're a.
It is, yeah, but it doesn't always play well
But anyway,
with other people in the practice. It doesn't
Malcolm
always
had
play well.
all of these things in his practice. He had the knitting needle card index. He
Yeah,
had an amazing system of repeat prescribing, and he had this thing called an e-book, which the Royal College of GPs said, you know, if you're teaching practice, you have to have an e-book. And an e-book stands for Eimerl, I seem to remember, Eimerl, is a book which has got a slot for every single patient you see, and you've got to fill a line. And somehow that interacts with the knitting needle. And I mean, I tried to kind of get my head around this, and unfortunately, or fortunately, um, yeah, well, Tim Benson, who
yeah.
people who are watching this will have heard of, he's still around in somewhere near Reading or Slough, I think. Might think about getting him on.
Mhm.
Tim Benson had developed this computer system called ABIES, and I came across that the first time I went to the British Computer Society's Oxford meeting, which was
Was
held
that
at.
was ABIES the first of the kind? Do you think?
So, well, no, there was another one called VAMP, Value Added Medical Products, and that came from Kent, I think.
Mhm.
Uh, and there were two systems which were kind of brand leaders because, although I believe that at some point between then and about 1990, there were 142 different systems available for general practice.
Yeah.
There were only two, and later three when EMIS came along, which really had significant numbers of GPs using them. And so Tim Benson had this thing called ABIES, and he met Ewan Davis, who was also around at those times. And Ewan Davis put together this scheme, free computer schemes, multi-terminal Unix-driven and computer systems in practice,
Mhm.
more or less within a year or two of me joining the primary healthcare specialist group. And
Cool.
similarly, VAMP put together a similar system. And so both VAMP and Ewan's thing, which is ABIES, which has been changed because of who financed it, to a system called AAH Meditel, started selling these multi-user systems. This is in sort of mid to late 80s. I think in 1987,
Yeah.
that's 3 years after I joined the primary healthcare group, we got one. So we were one of the first adopters of an AH Meditel system, and we started as a practice using it in earnest because I'd managed to persuade my partners that it was really important. And if you use a computer system properly, 2 years, you've got your disease index sorted out.
Yeah.
Because of
The effort that you put in to gather that data sort of compounds on itself, because you put in small amounts of effort to get the data in the right places, and then you can do searches and you can immediately get information back. That's really where GP records, computerized GP records, sort of leapt ahead in terms of what they can do compared to narrative records that don't have codes and aren't based around sort of problems and registers.
Yes. So, so with the help of an energized practice team, who I suppose I brainwashed into thinking that they were very skeptical to begin with. We had 2 receptionists and 2 practice nurses and a practice manager and 3 partners, and everybody was told to use it. We even used problem-oriented medical record because of my previous experience. So every consultation, if done properly, you would evolve the problem title. That's called transition. And there would be an envelope of consultation notes within there. And basically the problem titles were either active or dormant, and you could make your active problem list from that. And we did that right from the beginning, once I got used to understanding how to do it. And I don't think many other practices did that one, but we did it. And so we had a disease index, repeat prescribing was on the computer. We got to be a training practice pretty quickly.
I was a locum GP for a long time, and moving between different practices, you could see the variation in how well a different practice would pay attention to problem orientation. So some of the practices you'd go to had a very nicely problem-oriented record, where you would see the active problems, you'd see the inactive problems. Everything was kind of curated, and people would tend to add new information into an existing problem if it was relevant to that problem. And then you go to other practices where it was chaos and just people just entering whatever was foremost in their head as a code and some free text. And so you'd end up with the sidebar list in System 1 full of garbage, and you could not work out what the patient's current problem was. And in the shortness of a GP consultation, that sort of optimization matters, doesn't it? You want to be able to cut to the chase and see what main problems you're dealing with.
Yeah. Well, yes. And I mean, I kind of brush over it as though it was easy, but, we had 7.5-minute consultations in those days.
Wow.
And when we got a computer system, we realized it was impossible to do it in less than 10 minutes. So after much argument, we changed 10 minutes, and we had to work longer surgeries, and I guess we were more and more reluctant to do home visits. It was a practice which traditionally had done lots of home visits, and that wasn't popular, really. Cutting down on the number of home visits. It's always been a problem in my professional life, trying to weigh the number of home visits against the value of them, because it was very difficult. And if you're there's a high demand working class area, it's very hard to get out of that demand for home visits thing. But anyway, we did. And so after a few years, it became okay doing 10-minute consultations. And it was only when complexity started increasing as time went on that we'll get into the problem again, which we're right in the middle of now, aren't we? Because patients live longer, we're better at looking after things. The amount of complexity for many elderly patients is just mind-boggling. So I brushed over, glossed over another thing. I did buy a BBC Model B computer about the same time as I joined the British Computer Society, but I tried to learn BBC Basic program, but it's clearly not for me. I'm not somebody who
not a programmer. I didn't really take to it back then either. I mean, I was very interested in technology like you, very interested in programs and programming. but I wasn't very good at programming, and it took me a long, long time to get sort of back into it. I didn't do any computers throughout the entire thing of medical school and the first 10 years afterwards. I was doing hospital medicine 100%, and I didn't do any computering stuff until after I became a GP. So how did you get from there? So you're an early adopter of GP records. You're using AAH Meditel, so a pioneer in the north, certainly, as GP computerized records. How did you get from that into being more of involved in policy and the sort of health informatics group and that sort of thing?
So because I was interested in data. I mean, I was primarily interested in data and good friends with Malcolm Aylett. We had this system which compared largely teaching practices. There were lots of teaching practices in Northumberland. 50% of the practices were teaching practices. And they were all interested in collecting data, and they all computerized quite quickly. But anyway, before that started, Malcolm had created this system called MIQUEST, where for about 20 different disease groups, he would get people to fill in data about how many times they saw people with these diseases and submitted them. And he created this concept called the Northumberland bar chart. And you would get, I think, 30 different bars for diabetes mellitus or hypertension. And the one who's got the highest incidence was at the left, and it had a number, and they all went. So you knew which number you were, but you didn't know who everybody else was. And you could see that some practices were diagnosing diabetes 4 times as often as you were. So what's going on there? So with the help of computers, we improved our data collection, and we improved. So asthma was a particular interest of mine. And we had a huge number of asthmatics after a few years. Probably too many, but not really. I don't think so. And then we learned what is the process of looking after asthmatics, and you start to get outcomes like reduced hospital admissions and stuff like that. So the Donabedian stuff was worth learning, all that kind of stuff. So I got interested in thinking, well, wouldn't it be good if we did this on computer? So I've got this idea in my head that if we had a common output format for all of the different systems, and there were about 4 of them, not other, there was beginning to be DMIS. There was quite a lot of that, quite a lot of AAH Meditel, and possibly a few update systems. So I put this idea on paper and sent it to the Department of Health. So Glyn Headich told me there's a guy at the Department of Health called Jeffrey Rivet. Send him your proposal. I sent it to them, thinking, well, that chance. And about 3 months later, I got this communication saying, we think this is a really good idea. Can you work it into a proposal? So I called the proposal Common Output Format Linking Totally Unsimilar Systems, which is COFLINKTUS, which I was very pleased. Very pleased with that acronym. And I sent it in, and he said that if I could get the Northern Regional Health Authority to back the proposal, he would pay half, and they could pay half.
Wow.
So basically, in 1992, after a lot of work, we got £250,000 to put this thing together, COFLINKTUS. And I found David Markwell and asked him if he would help. And he kind of looked at it and he said, we're going to call it MIQUEST.
Yeah.
The morbidity information query export syntax. And he he did it. And I mean, it was, of course, nothing like I envisaged. I mean, it was anyway. It was a SQL type thing. It was
Yeah.
well,
Help query language. I
that's
mean,
very loud.
there's very little on the public internet about some of these things that we've talked about because they sort of happened in a pre-internet period, and then they've evolved and disappeared before the internet got around. So there's a kind of gap, and I think possibly the National Project for IT extinguished and exterminated a lot of these ideas, such that there's very little. So I've started a little archive on Open Health Hub, which I'll put a link to, which I'm mentioning because we have got an entry on MIQUEST, because I couldn't find anything about MIQUEST a few months back when I was looking for it. And so we're trying to collate more of that sort of remembered information and get it surfaced somewhere on the internet, because these things are useful. Um, as you know, as you describe, it's a way of getting the information out of multiple systems.
Yeah, yeah. And I mean, basically, it worked brilliantly once it was created. I mean, I could talk a bit about the project, but it's a little dull. But I mean, there was a woman called Elaine Kennedy who was head of IT in the Northern Regional Health Authority, and she employed somebody called um, Louise Simpson, who's now Louise Wilson.
Yes,
She's,
I
I think
know her
that
well. Wrote a book with
I
her.
think she was only about 21 or 22 when I met her, and she was the liaison person between me and the rest of the project team. So she worked presumably for the Northern Regional Health Authority, um, and a few others. But David Markle created it, and then once it come. I mean, there's another really interesting issue, and that is that once the project had completed and we had the tools, the Department of Health says, right, well, we've done the project, it's finished. Next. So no, hang on a minute. You've got to help us develop it to the tool and roll it out. And they're just not interested whatsoever in that kind of thing. And I came across this when I worked for BT later on, that they they
Yeah,
or tried to put the GP systems onto the cloud in those days. And once they'd done it, they declared business as usual, and you couldn't do anything to the system anymore. I was advising BT at the time, saying, "Look, this is complete lunacy. We depend on a continual dialogue between practices and the computer
yeah.
supplier to keep evolving the system.
I don't
It's
know
not
why that is.
once a year; it's every day. There's dialogue between various people."
They seem to have a central uh, preference to treating projects as completed, so that everything is a program. It has a beginning and an end, and actually a failure to see things as like an ongoing piece of work that needs to be maintained and improved, and will never really finish. And I think it's I don't know really why that is, but they have seem to have an obsession with program management and project management, and things are funded with a slice of money from Treasury for a project. And maybe that's why they think everything is compartmentalized and comes to an end, when in reality, these things go on. I had the same discussion with Denise Downs about SNOMED. So the
Mhm.
SNOMED project to SNOMEDize all of primary care was declared a success and a completion, and all the funding went away, and it's not done. There's still systems that don't natively use SNOMED. There's
Well, that will never be done.
yeah,
I mean, I worked with Denise. That became my main sphere of interest. Denise.
yeah.
Denise and I worked together on SNOMED. But I'm jumping the gun here. So where were we? Yeah. So that in order to make MIQUEST work, somehow we put together a project called CHDGP, Conducting Health Data in General Practice, and there was a project manager who was brilliant. called David Gearing, Gearing, from Exmouth, I think. And over 3 years, we worked to put together the idea of how could we continually collect data in general practice, and it would be using MIQUEST. And eventually, there was a call for contract at the end of it, CHDGP, and the University of Nottingham won that, and that became Primus. So I was working at the same time as being what I think I was the chair of. I was the chair of the CHDGP board, the CHDGP board, and I was also working at that time in Newcastle University with Ian Purvis in the Saudi Centre for Health Informatics, also known as SHIN, and we competed for that project. But Mike Pringle in Nottingham won that, which I think was fair enough because we had our hands full with a decision support project called Prodigy, which was huge and all-consuming and grew the Saudi Centre. When I joined the Saudi Centre, there were about 3 or 4 of us, and by the time the Prodigy project was going, there were about 100 people.
Wow. Well, that's a lot of people working on a project.
Yeah. So I've kind of missed out another bit of my life, which is how I got involved in encoding and classification. So I became really interested in the read codes, and after 7 years of general practice using the read codes in our AAH Meditel system, I was able to take a sabbatical because we had a 7-year sabbatical clause in our GP partnership contract, which was really good. I think I was the first person to ever use it. And I went and worked with James Reed in Loughborough for 6 months.
Cool.
And it was the very beginning of the clinical terms project, where we were evolving what at the time was called Read version 2.
5-byte read.
5-byte read, yeah. We used 4-byte read in the practice, which confusingly was called Read version 0. Don't ask. I can't even remember. I don't think. But
yeah,
it was version 1, and the clinical terms project, CTV version 3, it became known as, but it was Read version 3 at the time.
Yeah,
was started, and that was an absolutely fascinating time to join a big, hugely funded government project to build a new clinical terminology. And there were something like 42 specialist groups were created for each specialty, like dermatology, cardiology, general surgery, orthopedic, all that lot. There were 42 of them. And each appointed through its society or Royal College a group of people to create a terminology which was comprehensive to their specialty. And interestingly, at that time, I was working as the GP, and we didn't have a GP group. The argument being that we didn't need one because everybody else would contribute their bits, and we could just use that. And I was a bit unhappy about that. And we did eventually get a GP group together. I found myself in a difficult position, often because my loyalty was to the profession rather than to the people who were employing me, and got me into hot water quite a few times.
Yeah, well, I think that's an important thing about being a clinician, isn't it? That we do have a sort of an allegiance to patients in the profession is the highest, it's the prime directive, whereas employers sometimes don't see it that way. They think, I'm paying you and I'm giving you an instruction to do this, and you're saying, no, that's not ethical, or that's not the moral thing to do.
The right thing to do, yeah.
That's why clinicians are trusted, because we have that level of ethical oversight.
I mean, it's a huge issue in you might say Nick, you've been in clinical informatics since 1980, and it's now 2026. What difference have you made? Well, we've made far less difference than we should have, because of the inability of clinicians to sway the argument of the commercial and political world to do
Yeah.
things correctly. And I mean, they might say, possibly often correctly, that we don't always pursue the interests of the patient first. That there are clashes within Joint GP-IT committee. I'm sure you can remember.
But you could, on the other hand, putting it a different way, we do have good, solid clinical coding systems which were developed throughout that period. So read 2, CTV3, SNOMED, that then enable things like outcomes-based payments for GPs, QoF, and also things like the shielded patient list wouldn't have been possible without that work being done a priori. So, I mean, there is impact. There is big impact.
Huge.
But I get the frustration that you could have done more without the drag.
Health informatics at that time was the health informatics I got exposed to, because around this time I was beginning to work for Newcastle University, at least part-time, or get James Reed to pay for me to do things which I could persuade them were important. And we used to go to, from the early 90s, about 1992 onwards, there were a group of us, Mike Bainbridge, Ian Purvis, Peter Johnson, Neil Jones. We used to go to America because that's where informatics was. And we went to the American Medical Informatics Association meeting, and there were about 2,000 people, all doctors, interested in computerized medicine. And the principal thing that was exciting everybody was the development of Reed and SNOMED on different sides of the Atlantic.
Yeah.
And I was completely focused on SNOMED, really, and doing Reed to begin with.
Yeah.
There was a guy called Moon Mullins, who was a professor of general practice in Alabama, sadly recently deceased, and he was my mentor. Really, he encouraged me to do stuff, and he brought a few of us GPs over, and he made it his business to try to get general practice in the United States to use Reed codes. And he was up against the National Library of Medicine. I remember going to meetings, and he would stand up and he said, "Well, I'm just a country doctor from Alabama, but these guys in the United Kingdom are making fantastic progress with Reed codes, and we need to adopt it."
Yeah.
The Library of Medicine would say, "Well, we know you, Professor Mullins, because you worked for us for a year, so we don't believe that you're just a family doctor from Alabama." But anyway, it did make some headway. One day I found myself being called to see Betsy Humphreys, who was the librarian at the National Library of Medicine, and she wanted me to take the message to James Reed to tell him that they wanted to use Reed codes in the United States. So I went to tell him, and he was incredibly dismissive. I mean, you won't have met James, I don't suppose, but he was a very irascible kind of guy, and he told me in various expletive ways that he didn't want anything to do. It was hilarious anyway. But anyway, as time went on, the two entities merged.
Yeah, so CTV3 merged into SNOMED-RT, and you end up with SNOMED-CT.
That's right, and 70% of the concepts, interestingly, were CTV3 because of our clinical terms project.
Well,
whereas SNOMED was just a pathology, originating in SNOP, which I talked about earlier. So SNOMED was 30%, and we started having transatlantic meetings to merge the two. And that was a really fascinating part of my career as well. So I was
I find it fascinating that like CTV3 now is still currently available. It's out of date, but it's available on an open government license, or essentially Crown copyright. But its successor is on a less permissive license. So SNOMED is something that you have to license from SNOMED, And so, for example, developing open source software that bakes in SNOMED is not really possible because you have to get the user to add in an edition of SNOMED later on. And I find the SNOMED model of licensing to be it's harmed their own adoption because it's so difficult.
Yeah, I don't know how you get around that in the United States. I mean, I think it's a capitalist market economy, and I don't think they can come to terms with that. So,
I don't think you can fix it that way. No. Although interestingly, I don't know if there's a sign of change ahead because SNOMED have released the parts of SNOMED that relate to the international patient summary have been released on a zero license, essentially a kind of permissive license. And they've just extended that set this week. So maybe they're getting the memo that a closed proprietary licensed nomenclature actually harms its own adoption because countries that want to adopt it can't afford to. Tooling can't be built in open source because it can't be baked with the terminology in it. Maybe they're getting the memo.
yeah, it's always been the case. I mean, I also spent quite a lot of time working with the International Classification of Primary Care, which belonged to WONCA, World Organization of Family Doctors, and they still own ICPC. ICPC 3 is now out, and I mean that's run by a consortium of European countries, but not the same as WONCA, but or WONCA Europe. But the ICPC before that was fraught with problems about licensing, and it stopped the development. It's a kind of effective way of shooting yourself in the foot.
Yeah, it often costs more to administrate any kind of license terms than it would do to just let it be free. I think I've heard that ICPC 3 is looking at a Creative Commons shift and to move to a more permissive license.
They probably will be, yes. But it's an entirely different thing from a terminology. It's a classification. And those early days working for James Reed on my sabbatical, did the hard yards trying to understand the difference between classification and terminology, and they are clearly distinct. And because a classification is a categorization, and it's
everything should be able to fit into a classification somewhere.
Yeah, exactly.
Whereas terminology is like a descriptive language.
Yeah, I can't remember what I was going to say. It's a conceptual. That's right. Sorry, a conceptual terminology. So concepts in SNOMED can overlap in meaning, and they're not, like pigeonholes. They're like circles plonked down Venn diagrams, which makes analysis very difficult. And really, to analyze SNOMED, you need to translate it into some kind of classification, or else you get into a mess. But anyway, that's beyond the scope of this call, I think.
Yeah. So what was very interesting there when you were talking about MIQUEST, or the precursor of MIQUEST, is the idea that the Department of Health saw a good idea and essentially talent spotted that idea and said, that's a great idea. We're going to tell you it's a good idea. We're going to reply to you. We're going to pull you into our orbit, and we're going to fund it and make it happen. And that was MIQUEST. And that's just unheard of in the past 15 years. The idea that the center would build its own tooling, for example, has sort of been thrown out in favor of everything being outsourced. And one of the things I see a lot is innovators across the NHS, lots and lots of clinicians with good ideas. Some of them can code, some of them can't code. One way or another, they get to the point where they've got an idea that needs to exist, and they can't get any help from anywhere. And the nearest thing you can get to help now is the Clinical Entrepreneurs Program, which is heavily skewed towards it, telling you that you as a clinician now need to set up a business around this and sell it to people and make money and give up medicine and become an entrepreneur full time, because really it's hard to do medicine and anything else. instead of just saying, look, we accept this is a great idea, well, let's get it built, but you can carry on doing what you're doing. I mean, most clinicians with a good idea do not want to become an entrepreneur. They just want their good idea to exist.
Yes, and I mean, some good ideas get funded through the university system, through NIHR and stuff like that. But they're fraught with problems too.
Yeah.
And when I, after I retired from DH Informatics and what is now NHS Digital, but then was called HSCIC, I did go to Newcastle University for the last 3 or 4 years of my active employment.
Yeah.
And I came across all kinds of problems with projects in the university, which were being ruined by interference from DH saying, or from sort of from new statute saying, well, you're using data, we're going to charge you for it. And they didn't have any money because they finished they'd used their grant up, but they still continued to use the intelligence that they gleaned from their project. And they were told that if you want to use the data sources you've been using during the project, you're going to have to pay for it now. So they just closed down projects, which could be going on ad infinitum. It was tragic.
It's madness, isn't it? And I've seen that a lot, projects that have come to the end of their funding. And I think the problem does seem to be in the model of funding that we give to these projects. Everything is either grant funded or short-term project funded, as though it's a one-off thing. You build it like you're building a physical object, and once it's built, it's finished. When we're not dealing with that, we're dealing with like an intangible long-term project, and it needs long-term funding if it's going to continue to exist. But there's really nobody that seems to get that in a position of power. And our digital leaders in certainly in England, I have probably been on record as having quite a low opinion of, because they just haven't led. They have essentially followed commercial imperatives, followed the existing systems around funding, and nobody's said, I'm a leader, things need to change, this is how you do it, let's make it better.
I don't think it's very easy. I mean, I do think that when we grew up with our GP suppliers back in the 80s and 90s, that we had some kind of symbiotic relationship. We were a partnership, really, between the users and the suppliers. And I was rudely woken from my lack of knowledge when I joined BT. So after I worked for the Prodigy project and other things in Saudi Centre, I realised that I was going to either have to go back into general practice or get another job. So I got a job with Capgemini, and Capgemini were competing for the national programme for the East of England, whatever it's called, component of the national programme for IT, and worked for a year on that. And it was the most exciting thing to do. There were a whole bunch of really clever people came over from Ernst & Young in America, and they brought their technologists with them, and we were building systems which could show the NHS what they would do if they won, and they didn't win. And they continued to employ me for a little while, and I thought, well, I really want to join BT because they'd won all the contracts. So I got a job as a terminologist contractor working for BT, and soon realised what the problem is. And the problem is that you basically win a contract. If you're BT, you win a contract. Then you've got 3 years to deliver your project. And at the end of that time, you've got to walk away, and it's got to be finished. And delivering a massive program like the spine, or like a single hospital and GP system for London, those are the two things I got involved with initially, is massively complex. And particularly the spine there were terrible battles going on between my bosses in BT and Richard Granger, who was head of the National Programme for IT. And basically, Richard Granger didn't believe they were delivering fast enough to have it finished in 3 years. So he kept getting nastier and nastier and told them who to employ, basically, to solve their problem. So they would employ and outsource some of the expertise to different organisations that we've never heard of, and
Yeah.
you're not the right place to name them. But what they did was really clever. And what used to happen is that BT would say, well, over the next month or the next week, we're going to develop these features for the spine, and we'd like your comments back by the end of the week, please. And the centre wouldn't return the proper comments back by the end of the week because there was massive stuff. It'd been compiled by huge numbers of people and only a small number of people at the NHS end. And so deadlines just scraped along. Well, these new guys came along and they said, right, on Friday, you're going to get these things delivered unless you tell us otherwise. And so Friday came along and they didn't sort of say, where are your comments? They just said, you sent us no comments, so we're going to develop this over the next week. And it would just go like that. So they just developed it just like they wanted, really. And there was very little input. It was quite difficult as a clinical team to get input into that. It was a lot of fun, but you just see that actually, if you employ management consultants and delivery organizations to run projects, you've got to have a different commercial paradigm altogether than this cozy little family of the practices and their GP supplier.
Because it's kind of a strategic malicious compliance almost, isn't it? Saying, I'm going to build this and you've got until the end of the week to give us some notes on it. Because knowing full well that the organizations couldn't return any opinions in that shorter time frame. So then you could just go ahead and do what you want. It's knowing calculated.
So this ruthlessness of the people who delivered a spine, and it was translated into the London programme, which delivered lots of hospital systems that worked. And if you look at the other parts of the national programme which weren't funded by BC, they didn't do so well. I mean, the sort of story about the South, which ended up in tears with, I think they were called Fujitsu, and BT ended up delivering all of the projects in the South using their rollout method with them.
It's an interesting story to read about. So I'll link to some information about the national project because it's a big disaster, really. But there have been books written, and there's a good Wikipedia entry that talks about some of the failings. But I think in the end, they reckoned that something like 2 to 3% of the benefits of the national project were eventually realised. The spine being one of them, and probably NHS Mail being another one. And a lot of the rest of it just collapsed after £12 billion was spent on it.
Well, BT did deliver Cerner systems into the South and into London, which gets people onto the learning curve. I mean, I think it's quite interesting. So one thing the first place we tried to deploy a system, and I was involved because of SNOMED, was St Mary's Hospital in Sidcup. And they were really nowhere with IT. And they were the first to volunteer because they were nowhere with IT. And then the next hospital on the list was the Royal Brompton. And the idea that BT had, which I kind of cringed at more than that, was that we're just going to deploy the Sidcup system, which had been built with the help of Sidcup clinicians, to the Royal Brompton. And the Royal Brompton quite predictably said, you must be joking, sunshine. So this idea of commoditization of a system was not possible. And that there's an adoption curve, which is a sort of, whatever you call that distribution, Gaussian distribution. What's it called when you have a...
It is Gaussian, Poisson curve, a bell curve.
Yeah. And you have early adopters at the left and the majority at the top and laggards at the end. Well, the trouble was that BT were using the laggards to be the first systems to seed the rest of it because they were the most compliant. It's never going to work.
Never going to work.
So the idea of a commoditized system never happened. And so that's one of the problems, that if you're going to build, so let's say 20 Cerner systems, and you're going to do it within the project budget that you've managed to get, despite it being so huge, if you can't get them all the same, or the vast majority of them the same, in terms of their coding, it's never going to it's never going to work. And I remember that one of my first days, we had to define the blood pressure for a hospital or a GP system that we were building. And I said, well, surely there are standard blood pressures.
Yeah.
Fine hypertension within this system, which is being used across the whole of the United States of America. And they say, oh no, it's got to be tailored for each individual instance. So I'm looking to BT saying, no, you've got to have all the same.
That's the madness, isn't it? That's the data modeling.
No, it's part of the tailoring solution. Well, of course it is, because they want all of their systems to be different, so that they're effectively locked in. If everybody had exactly the same data structures within their system, then it would be much easier to move on to the next, after 10 years, onto the next.
And that legacy of bespoke data models is the problem that has led to us having the difficulties we have now with interoperability. So we're trying to create joined up data across the NHS, and we can't, because every single trust has a different data model, radically different.
They all have a different data model. They've all got a different information model. And Ewan and I used to be good friends. Ewan worked with me in BT. Ewan and Neil, for example, worked with me in BT. And Ewan subsequently did a lot of work with fire in the medicines domain, I think. And he said the problem still remains. Each instance of fire, you have to transform if you want to intercommunicate with another instance of fire. It's not solved. Their archetypes are slightly different. So my last job before I retired with HSCRC was Director of Clinical Standards Implementation. And it was a soul-destroying job because, I mean, to be blunt, nobody really understood what standards were. You know, if you tweak the standard for each hospital, it's no longer a standard. Imagine if you bought a mobile phone and each village had a different, had tweaked the standard for your mobile phone for its mast. Nobody would
just nothing would work
at all. So you would think that BT would get this. Well, they probably did at some level, because they use global systems for mobile telephones. But we're nowhere near that in the NHS. I mean, it's just
globally, healthcare is nowhere near that, because we've adopted databases which are harmful to interoperability. Because everybody's got their own little data model and it's so easy to have a separate one. We're still waiting for an USB moment in healthcare. So you're probably old enough to remember how computers used to be, when every computer manufacturer had its own peripheral plug, and it would be 8-pin, or it'd be 9-pin, or there'd be a 2-pin, or there'd be a 17-pin. And every single manufacturer had their own bespoke peripherals and their own bespoke peripheral connectors, and nothing worked with anything else. And you couldn't buy a disk drive from a BBC Model B and plug it into an Apple. And then USB in the sort of late 90s, early 2000s, suddenly it's all solved and everything can plug into everything else. And so much of what we take for granted now about interconnectivity, even the stuff that I'm using for this podcast, it's all USB.
But the bottom line is that proper standardization is the enemy of commerce. And everybody in a commercial entity wants to screw up standards as far as they can, so that they keep their market share and they keep their ability to customize and lock people in. And it's so when you try to standardize, you're competing against the market forces of industry, and that's the problem.
It is a problem. I like to think that open source is a way to solve some of that. If you, for example, some of the very rapid developments of projects that have happened in the last few months related to things like OpenClaw and LLM-driven things, all of that is open source. And the part of the reason it can go so fast is because when a new standard like a Claude skill comes out, it's just there and everybody can immediately use it. And so it becomes a very rapidly adopted industry standard. And that's where there's a kind of sweet spot there where open source can drive everybody to standardize and still make money. Whereas an older model is that standards are the enemy of commercialization of your product,
Yeah.
Just before we finish, do you want to talk a little bit about the Great North Care Record? That's something that you were closely involved in towards the end of your career.
Yeah. So I got called out of retirement by one of the professors of renal medicine at Newcastle University and the RBI/Freeman Hospital in Newcastle, NUS, as we called it, Newcastle Upon Tyne Hospitals Foundation Trust. And he told me that they'd won, or they hoped to win, £4 million from George Osborne's Northern Powerhouse project, despite the fact that George Osborne is no longer there, in a project called Connected Health Cities. And so there was a £16 million pot for 4 quadrants of the north. There was Liverpool and around there, and Manchester in the northwest, I think, and Yorkshire on the side and the northeast. So we had to write a bid, and we won the bid. And we started this £3-4 million project by getting together a number of data collection projects, and the idea was to improve interoperability across the region and improve data analytics across the region. Those are the 2 main aims. And it became apparent quite early on at the beginning that Mark Westwood and Joe MacDonald had already thought this name at the Great North Care Record. So he called the project the Great North Care Record Project, as well as Connected Health Cities. And my job is design the configuration. Well, I mean, obviously, I'm not an IT designer, so I basically got some help, and we had this idea of creating a hub, and we tried to proselytize the idea that there would be a series of hubs across the 4 regions, which would interconnect with one another, and this idea of cascades of hubs, all transmitting data in the same format, if you like. And so to work out the architecture of this. And so we set out a technological prospectus, and then started working with the CIOs of the hospitals in the northern region. There were about 14 or 16, and we used to have regular meetings with them and work our way through. It was politically quite challenging, as I'm sure you can imagine. And after 3.5 years, the money ran out, so I left. And the political situation didn't look ripe to me. But shortly after I left, there was this thing called COVID. And all of the political considerations that were going on, enmity between north of the Tyne and south of the Tyne, between Wearside and Teesside, Wearside and Tyneside, and between Newcastle University, which is a big teaching hospital, and all the other places, just disappeared. The idea was to have a proper federated system across these hubs, which meant that the members of the federation would design the hub between them and have an agreement. And that was quite difficult because they're used to procuring systems based on their own requirement, not on the requirements of a pool of 14 people. And so it was running into the ground, but basically, Graham King, who's CIO of Newcastle, has had a large informatics team, about 120 people, I think, compared to some of the trusts who only had 6 or 7. So that's quite interesting, the size of the organisation and how they fund them, and the expertise of them. Newcastle took upon themselves to be the hub. So it was a hub which was subscribed to by Friends University, which were the other 12 or 13 hospitals in the region, and it works. Cool. Using document interoperability, really, and that's quite an interesting thing. I'm sure we could talk for an hour about document interoperability.
Oh, I could.
Because document interoperability is really important, and one of the things which I learned really is that if you're worried about the provenance of data, we have a system in medicine which already records the provenance of data, which is basically a discharge summary or a referral letter, which is signed by individuals who are responsible for them.
Yeah,
and basically, you can get the provenance and all of the all of the attributes of information from that. And so a document exchange system, I think it's sort of variants of XDS, was at the heart of the hubs.
Documents are the solution. Databases are harmful. Databases are where all the problems come from, and all the unreconcilable differences between silos, where we can't connect this silo to another silo, and you end up with the proliferation of silos and silos at bigger and bigger scale. All of that goes away if you start using documents. And that's how everything else works. If you think about how does business work? Well, what do business people do? They write documents and they email them to each other, or they use another transport layer, and they can store documents anywhere they like. And why is it so easy to do interoperability if you're not using a database? And the answer is because documents are the solution to it. That absolutely, for the Great North Care Record, and for some, there's a project I'm working on at the moment, which is using that sort of approach.
So the last message I have is about federation. First thing I learned in the national program is that enterprise architects are architects for enterprises, and the NHS is not an enterprise. So enterprise architects basically lock in the area that they're responsible for, and they draw a line around it, which is a frontier. And getting data transferred across frontiers is fraught with difficulty. Federations are groups of like-minded organisations who share a solution by consensus. The NHS is more like a federation, but only given that all of the component parts have got a say in the solutions they're got.
Yeah.
Federated data platform, which is being created, is possibly a misnomer because it may be a mandated data platform, which is a different kettle of fish altogether.
Yes, it takes away choice and collaboration. It's just, you will have this.
Exactly. And that makes such a difference.
That's been really lovely to have a chat about, and we've covered a great breadth of GP stuff and informatics stuff and terminology stuff and some political stuff as well. It's been really good. We've mentioned a couple of people actually who are no longer with us, particularly Ewan Davis and Neil Jones, and I would like to do an episode at some point covering those guys. And I feel as though we should definitely get you back on to talk a bit more about terminologies, because I know that you are a significant scholar of the terminology, and I would love to get you back on to talk a little bit more about that in the future.
Well, there are others, of course, and I don't know that they would hold me in as high esteem as you appear to. But yeah, I mean, I'm happy to. I don't profess to be the biggest SNOMED authority around. Far from it. I'm not. There's a guy called Charlie Stuart Buttle who knows a lot, and Jeremy Rogers, of course, Mr. SNOMED.
Absolutely. Mr. SNOMED. Yeah. Well, they're on the list. They're on the list. We'll be bringing them back to talk about terminology a bit more in the middle of this year. Anyway, Nick, thank you so much for coming on the show, and I'm sure we'll have you back to talk about terminologies.
Well, thanks very much. I've really enjoyed it, and thanks for letting me say my bit.